Hey, what's up? How you doing? Today we're talking about parathyroid and thyroid disease, cancer. This lecture is a little complex, it's very dense, but we're going to simplify it. We were just talking about thyroid disease, so we're going to continue with thyroid cancer. We'll come back to parathyroids. Quick anatomy lesson. Thyroid sits on the anterior aspect of the trachea. It has a right lobe and a left lobe. The middle is called the isthmus. The parathyroid glands themselves don't sit in the thyroid. They sit para, or right outside the thyroid, right at where the superior and inferior thyroid arteries come into the thyroid. This is the middle thyroid vein. So this is looking at it from the front or from the back, it looks the same. These parathyroid arteries kind of come posterior and shoot anterior because everything is kind of curled around the trachea. So if you look at it from the back, it does look flat, but if you look at it from the top, as soon as you look at it, you won't see these arteries until you start mobilizing them, tricking surgery. Spoiler alert, you have to ligate the middle thyroid vein first before you start mobilizing anything else. Now, a goiter itself is basically an enlarged thyroid. You can have a single nodule in the goiter, you can have a multinodular goiter. These are sometimes and usually caused by iodine deficiency, but we don't see really huge goiters in the United States anymore because there's iodine in salt. The only time you don't have iodine in salt is if you're doing sea salt all the time. Again, biopsy, thyroid nodule greater than 1.5 centimeters. Now, when you come into the office, first thing we're going to do is get a ultrasound or something to look and see. There's going to be a reason. What you may have had symptoms, you may have had weakness, you may have had you were tired, hot, cold intolerance, whatever, but we get a TSH level and look. Low, high, normal, whatever, we usually get an ultrasound. The ultrasound is going to either show something that looks benign and we're just going to follow up. So it's a centimeter or a small cyst, centimeter nodule or a small cyst, or it'll show something that is concerning. If it's concerning, we stick a needle in it. But before you do that, you have to make sure that your labs are okay, because if you stick a needle in something that's bad, it's a problem. Basically, at the end of the day, somebody walks in your office, symptomatic thyroid disease, get an ultrasound. If the mass is greater than 1.5, biopsy it. If it's less than 1.5, you can watch it, but most people will still get a biopsy anyway. Now, what you're always trying to avoid is thyroid cancer. Cancer in general, you always try to avoid cancer. But in this particular situation, we're talking about thyroid cancer. We'll get to parathyroid stuff later. Thyroid cancer is a little different. We'll go over the classifications. But there's one really we usually see about 90% of the time. Papillary adenocarcinoma. This is the most common type of thyroid cancer. It's slow growing. It's usually only on one side. It is almost never fatal. If someone dies from thyroid cancer, it's usually medullary carcinoma of the thyroid, or definitely anaplastic thyroid. These patients always die. Follicular is just a little more complicated to treat, but it still has a pretty good overall outcome. When you stick a needle in someone's neck, you'll start to look for follicular cells or abnormal capsular invasion. Those are terms that you'll hear, but that's really for a follicular cell to figure out if it's a follicular adenoma versus follicular adenocarcinoma. Follicular adenocarcinoma has to come out. Follicular adenoma, if it's small, you can watch. But we usually take those out anyway if they're greater than 1.5 centimeters in size, or we're worried. The average person comes in, thyroid ultrasound, for whatever reason, they come in with a 1.5 centimeter nodule, and they want you to tell them whether it's an adenocarcinoma versus not, or abnormal cells. You take them to the operating room. It comes back papillary adenocarcinoma about, like I said, 80 to 90% of the time. This is done on frozen section. You're only taking out one lobe. When this comes back papillary carcinoma and not a benign lesion, you go ahead and do a total thyroidectomy. All of these get a total thyroidectomy. with the exception of anaplastic thyroid cancer, and I'll explain to you why it's a little different. If it's not papillary, it's usually follicular. This is usually due to iodine deficiency, and again, it's not really a big problem now because everybody gets iodine in their salt unless you're doing Himalayan pink salt. And then they actually make sea salt now with iodine, so it's pretty cool. And this one still has a pretty good prognosis. Once you get these two out, you then have to consider radioactive iodine treatment. Radioactive iodine treatment works for a small amount of residual thyroid tissue. If you have a lot of thyroid tissue left, you may have to do a second surgery to remove it. That's why you can't just take out one lobe, find out you have papillary adenocarcinoma, and then just go ahead and leave it. You have to give them so much radiation that it's not worth it. So we end up having to remove that lobe so that they can complete their treatment. The other caveat to both of these is if you remove them, treat them, they come back with metastatic disease. The metastatic disease is not treated with radioactive iodine. It's a completely different beast. So you need to make sure that you get all that tissue out at the time of the operation. Medullary thyroid carcinoma, malignant C cells, it always shows up on a test which produce calcitonin. 4% of thyroid cancer is very rare. It can be sporadic, but it is usually familial. It is a lot more difficult to treat. This is an aggressive tumor. This is, if you hear someone say they got their thyroid out when they were young, it's usually medullary. They got it out, but they didn't have cancer. It's usually because they have one of the MEN syndromes or something that has a familial association, and they cut it out early. Anaplastic. Anaplastic is a bad boy. This one is usually not treated with surgery because these patients don't even make it to surgery. They come in your office, have a nodule in their neck, they come back 2-3 weeks later for surgery, and it's 4 times the size. They stop breathing. Anesthesia will barely put them to sleep. You'll take them to the operating room, open up their neck. It's just mush. There's nothing you can do usually in the operating room unless these are caught super, super early. And even if they're caught super, super early, the patients still have an overall poor prognosis. One of the most grisly deaths I've ever seen in surgery. Actually, 2 of the most grisly deaths I've ever seen in surgery were both anaplastic thyroid cancers. One was a guy that was 22 years old, young, really nice guy, funny, came back with a diagnosis of anaplastic thyroid cancer. He died in less than 3 months. Other patient was a patient of mine that I was operating on here and came in. F&A was weird. He said he had a trip he had to go on. He went on his trip, came back to my office 2 weeks later. The thing had quadrupled in size. He still wanted to go to the operating room. Took him to the operating room. We were just scooping mesh and nastiness out of his neck. Closed him up. He died like a week later. It's just hard disease. But that is not these two. People get papillary cancer all the time of the thyroid and do fine and don't ever worry about it. I went fast. Just remember this. Papillary is of the people. Most common one. Follicular has lymphatics, can spread hematogenously, but papillaries of the people, it goes to lymphatics, not hematogenous spread. That's why it's a lot easier to treat. Now, parathyroid disease. Again, parathyroids pretty much regulate calcium. That's all you got to remember. The thing that's always on the test is stones, moans, groans, and psychic overtones. So when patients have hyperparathyroidism, they have this calcium that's elevated, and they are have this mental stuff going on. They're kind of confused. They may have kidney stones. They may have some aches in their bodies they can't explain. Full set of labs. pH is elevated. Calcium is elevated. So they send them to us. We take them to the operating room and figure out what we're going to do. But there is a little workup before. A sestamibi scan can actually locate where that parathyroid adenoma is. Remember, it's right, left, upper, and lower. So you got to figure out which one it is. You can do a limited neck dissection and remove just the adenoma, send it off during the procedure to make sure that it is adenoma, and then you're usually done. Unless they have other problems like renal insufficiency, they can have all 4 glands hyperplasia and you have to take out one. So you may have to take them all out. And then what you do is you reimplant one in the arm, okay? What you're essentially doing is acknowledging that they don't need all 4 glands because they're producing so much calcium that reducing the amount of calcium that they can increase into their bloodstream by harvesting it from their bones, you want to limit that osteoclastic activity. Osteoclast build, osteoblast build, osteoclast destroy. So you want to prevent that. Now the trick is, the reason we put it in your arm is real simple. You put it in someone's arm at that time, and again, we're not talking about adenoma, we're talking about hyperplasia. You end up every once in a while having someone that is refractory, and you still have to go in and take out that thyroid. That means that parathyroid. Removing a parathyroid from an arm that's been implanted can be done in the office. It can be done as outpatient surgery. A redo neck dissection is a beast. So that's why we talk about implanting it in the arm, just because it's an easier operation if we have to go back. That's pretty much the sum up of parathyroid adenoma, but we're going to go through it real quick. So parathyroid glands produce PTH, maintain calcium homeostasis. That's all they do. Calcium is real important because it's what your cells need to act right. They have to be able to carry signals, nerves, all kind of stuff. So that's why you get all these weird symptoms. If you have hypoparathyroidism, which is usually after we do a total thyroidectomy and we believe we left all the glands and we don't, or we beat them up pretty bad and they're not working like they're supposed to, your calcium can drop and your parathyroid hormone can drop. And there's some autoimmune diseases that will cause it. In that case, fatigue, paresthesias, muscle cramps, facial muscle spasms is kind of cool. I can't remember if it's called Trousseau sign or not, but you can tap on somebody's jaw and it'll kind of spasm. What's that called? Isn't that what that's called, Christine?
I think so.
Yeah, I think so too. So you just tap on their jaw and it kind of does a little lockup thing. And the patients will kind of describe this pins and needles feeling. Their hands don't work, really crampy, hand pain, arm pain, leg pain. In that situation, you have to get their calcium replaced urgently. Now, hyperparathyroidism is what we usually see in a general surgeon's office pre-op, and it can be caused by an adenoma, usually in the upper lobe for me. For some reason, most of mine have always been in the right upper lobe. I don't know why. Or radiation exposure can do it. These patients sometimes are symptomatic. They'll come in with a calcium of 10.6, 10.8, but fatigue, depression, joint pain, muscle weakness, so moans, groans, stones, moans, groans, psychic overtones, calcium stones, kidney stones. Parathyroid cancer, usually in their 50s, very, very rare. I've actually never seen a case of it yet. Heard about it, never seen it. Workup, parathyroid hormone, calcium, 24-hour urinary calcium. If there's a question, you can do all this other stuff. CT of the neck is a good option. Sestamibi scan, I like to do them. I actually like to do a CT scan of the neck with IV contrast to look for parathyroid adenoma first. Then I'll use a sestamibi scan done about 1 to 2 hours before I do surgery, localize the gland, and then use the neoprobe like we do a breast sentinel lymph node to locate the gland. You can also do intraoperative PTH levels because once you get the right one out, it drops pretty quickly. So that's actually a very good test as well. Treatment, symptomatic, parathyroidectomy, remove the one. You can talk about primary, secondary. That's a whole nother lecture, but we'll worry about that later. Touched on it in the beginning. If it's asymptomatic and your calcium is a little high, you can watch it. But it'll grow and it'll eventually have to come out. Medications, dietary supplements, all this good stuff. At the end of the day, remember, for parathyroid adenoma, the answer is surgery. If you have 4-gland hyperplasia, the answer is surgery. If you have a thyroid nodule that's big, growing, surgery. If it's a thyroid cancer, surgery, unless it's anaplastic thyroid cancer. You would love to be able to get those patients caught early, but I still think they have an overall bad prognosis. That's it. Parathyroid, thyroid stuff. Still more to learn, but this will get you through the basics and get you started. Questions, give me a call. I'll get them answered. Text me, like and follow, all that nonsense. All right, guys, take care.